Well, good morning. I'm Tim Sheehy, president of the MMAC, and welcome to the Business of Metro Milwaukee, a monthly webinar spotlighting the challenges and opportunities to growing the region's prosperity, providing insights to help you make better business decisions and information to help you shape the region's future. Today's program is sponsored by United Healthcare. United Healthcare partners with the MMAC to make it easier to find a health plan that works for your employees and your bottom line. So work with an MMAC affiliated broker and you'll receive discounted rates on United Healthcare's All Savers plans. You also have the option to add other United Healthcare plans to your employee benefit package, such as specialty plans and supplemental financial protection plans for groups with as few as 5 employees. So contact your MMAC broker or visit MMAC.org to learn more. Well, we kick off the 22 series, and it's going to sound a lot similar to 2021 and how best to deal with COVID. We're a year wiser. We're dealing with new variants and questions about whether we're moving from a pandemic to an epidemic. Do masks work? If so, what kind? How best do we deal with these issues that remain front and center for our employees and our customers? Joining us with the latest information and fact-forward answers are Dr. John Raymond, President of the Medical College of Wisconsin, Dr. Ben Weston, Medical College of Wisconsin Associate Professor and Chief Policy Advisor for Milwaukee County, and Dr. Laura Cassidy, Professor and Director of Epidemiology in the Institute for Health and Equity at the Medical College of Wisconsin. So Dr. Raymond's going to join us with some opening slides, followed by Dr. Weston and Dr. Cassidy, and we'll get to your questions as soon as you populate the Q&A or the chat. And so Dr. Raymond, Happy New Year, and thanks again for you and your team joining us to help us think through the best ways that we can keep ourselves safe and the economy moving.
Thanks, Tim, and Happy New Year to you, and good morning to everyone. I'm so pleased to be joined today by Drs. Cassidy and Weston, really two of the best faculty members that we have at Medical College of Wisconsin. And also just want to start out by acknowledging that our data analyst, Ali Namadi, was accepted to a doctoral program in informatics at the University of Wisconsin, Milwaukee. So we'll keep him in our community and hopefully he'll come back to MCW as a faculty member. And we really want to express our appreciation to Ali for the great work that he's done to support us. If I could go to the first slide, please. You'll probably notice that these numbers are huge. And what I want to just start out by acknowledging is that Omicron, the new variant that was just discovered in South Africa right before Thanksgiving, has been a game changer for us, not only in terms of how we manage the pandemic, but how we think about the numbers. So I'll just start out by acknowledging these numbers are unprecedentedly bad compared to what we have seen earlier in the pandemic, and they probably underestimate the burden of COVID-19 in our communities right now. The good news, as most of you know, is that Omicron is a milder variant than the ones we've experienced before, but it is not a mild or risk-free variant. And this is something we'll be talking about. So the 7-day average in Wisconsin for newly diagnosed cases is over 9,000. And recall that at the peak of the surge in November 2020, the highest single day that we had was just under 8,000, and you can see that on the right. And the numbers are growing, and they probably are a gross underestimate of the actual burden of disease in our community because of the lack of availability of PCR testing, and because many people are using rapid antigen tests at home, getting a diagnosis, and not getting the PCR test. Positivity rates are going up through the roof. That 27% is probably actually low. And remember, we want that number to be significantly under 5%, or it means that we're significantly underestimating the community transmission of COVID-19. And our R value is significantly over 1, which means the pandemic is expanding and not contracting. Similar trends for Milwaukee numbers. Our 7-day average is 1,800, And that average exceeds the previous high day that we had in November of 2020 at 1,649, high positivity rate, high R value. Next slide, please. I'll talk about the deaths, which are really important, and we'll be monitoring these. They're flat to slightly increasing at 28 per day. And recall that as recently as last September, we were having low single-digit deaths from COVID-19 reported in Wisconsin. Hospitalizations are just about at the old high, which we saw on November 17th, 2020, at 2,277. We're 2,259 and rising. ICU census also is near an all-time high. Just a few days ago, we had 475 people in intensive care in Wisconsin with COVID-19. And our previous peak, November 2020, was 456, and the trend is unfavorable. And our hospitals and ICUs continue to be stressed with a high caseload. 96% of the ICU beds are occupied, and 92% of our hospital beds are occupied in Wisconsin. And unfortunately, this has been the situation we've been dealing with now for the last 3 to 4 months. And I would point out that unlike the last 3 to 4 months, we have many frontline healthcare providers who either have an Omicron infection or have been significantly exposed. And these individuals are on the sidelines right now. So full hospitals and full ICUs are straining us, especially because we have reduced staffing. And again, trends in this region, the HERC7 region, show high ICU caseloads from COVID-19. In the interest of full disclosure, I want to say that 24% of Wisconsin hospital beds are occupied by COVID-19 positive patients. So the majority of people in the hospital don't have COVID-19. On the other hand, this high caseload makes it difficult for us to take care of other non-COVID patients. And in fact, our emergency departments now are backed up with patients who are waiting for beds for a variety of reasons. And that makes it less efficient and more difficult for us to process patients that need hospital care. And I do want to say, if you want a COVID-19 test and you are not urgently ill, please do not go to the emergency departments to be tested. We have such a backlog there that we really don't need people that are not very sick in the emergency departments. Now, in terms of how mild is COVID-19 right now, with Omicron constituting well over 95% of the cases, it's still bad. 11.4% of hospitalized COVID-19 patients are requiring ventilator care. Next slide, please. Just some screenshots from the Department of Health Services in Wisconsin showing the significant surge in cases. You can see by the 3 circles on the top that new confirmed cases, new probable cases, and test positivity rates have skyrocketed over the last several weeks. Interestingly enough, and hopeful for the future, our deaths, although they are high, the daily deaths, have not shown a significant uptick yet. And we're going to talk about that in a little bit more detail. But what we know from other communities is that the increase in deaths happen about 3 weeks after the increases in cases of Omicron. And recall that Wisconsin did not have a preponderance of Omicron until around Christmas time, the week between Christmas and New Year's, is when Delta started to decline significantly, and Omicron was the predominant variant. So we're going to know more about what's going to happen with our deaths here in Wisconsin this week and next week as we reach an inflection point. Next slide, please. Okay, I show this very frequently, and this is just a picture of Wisconsin's 72 counties with the case burden starting in November of 2020 and then proceeding to the right to the current state, which you can see on the far right. Now, I do note that the color scheme has changed on the DHS website, and we can only go back 6 months to grab the pictures. So you please bear with me to see that on the left, red and dark blue are very bad. We improved as vaccinations started at the beginning of 2021, and we had very low case burdens right around the 4th of July when Delta came on the scene. Now Omicron is the predominant strain, and you can see that we're dealing with 25 counties with very high case burdens, shown in the orange counties, and 47 with critically high burdens. And I would say that the aggregate burden in the state is higher than we have ever seen before. And it's rising in pretty much every county. Next slide, please. So what do we know about Omicron? We have to rethink everything that we knew about COVID-19 because this variant is very different, and we only have 2 months of experience with Omicron in the entire world. Case counts are higher because of the massively increased transmissibility of Omicron. And I want to say that case counts still matter, but only in the context of a broader set of metrics. And we'll know more as we gain more experience about Omicron, about the connection between case counts and hospitalizations and deaths. So what we used to know about Delta, Alpha, and Beta strains was a pretty predictable relationship between case counts, hospitalizations, and deaths. There has been a decoupling caused by Omicron. We will probably know more and be able to predict more accurately in the coming weeks. But right now, what we know is that cases of Omicron are about 1/3 to 1/2 as likely to result in hospitalizations and deaths as our recent experience with Delta, which was similar to what we had experienced with the previous waves. We also know and acknowledge that a substantial percentage of people in the hospital with PCR confirmed COVID-19 are patients who have an incidental infection that was detected as people were admitted to the hospital for other causes. So this is important that we distinguish hospitalized from versus hospitalized with COVID-19. On the other hand, I must stress that incidental does not mean insignificant or trivial. Indeed, Omicron and all COVID-19 complicates the clinical care environment, and it exacerbates comorbidities, and it is very likely to increase both the morbidity and the mortality of patients with significant non-COVID-19 diseases, such as cancer, heart attacks, strokes, and other infections. So this is something that we need to monitor. And I want to stress, we can't just assume that because a large number of patients in the hospital have incidentally detected infections, and it may be in the range of 40 to 50%, that this is not a problem for them or for the healthcare systems. Next slide, please. Omicron can be pronounced a bunch of different ways. You see them on the top. It has about 4 different dozen mutations, making it significantly different than any strain that we've dealt with before. It is significantly more transmissible, 2 to 10 times more transmissible than Delta, which was one of the most transmissible viruses that we've ever dealt with, on the order of transmissibility as measles and chickenpox. That mutations change the spike protein, and that has raised real concerns about immune evasion, because antibodies that we make from a previous infection or from vaccinations really focus on specific sequences in that spike protein. Omicron has been detected in nearly every country and every US state, and it has virtually extinguished the transmission of the Delta variant in South Africa, most of Europe, and most of the USA. As I mentioned, it's much more transmissible and highly contagious than any other strain we've encountered before. We also know that previous infection with other strains of COVID-19, the Beta, Alpha, and Delta strains, or so-called natural immunity, and vaccines provide less protection against Omicron infection. But we do know that a full vaccination status, and especially those who are fully vaccinated and boosted, provides significant protection from hospitalizations and deaths, and also some protection against getting even a mild infection or spreading that to other people around you, whether you're asymptomatic or not. So again, we want to highlight the importance of vaccination and boosters in protecting yourself and those around you and reducing the transmission in our community. Next slide, please. Thank you, Chris. So what's different about Omicron? We've already highlighted some of the differences. Also want to point out that the incubation or the latency period between exposure to symptoms is much shorter than for other strains, on the order of 2 to 3 days versus the usual 5 to 7 days. The doubling time in populations is astonishingly fast, 2 to 3 days in the early phases of transmission in a community. And the symptoms do seem to be milder: cough, stuffy or runny nose, headache, fatigue, scratchy or sore throat. But that doesn't mean that some people can't become seriously ill very, very quickly with the Omicron strain. And there is a physiological basis for the predominantly upper respiratory symptoms. There's significant accumulating evidence that Omicron is much more capable of infecting tissues in the sinuses and in the bronchi of the lungs, but less effective than previous strains in causing pneumonia or infecting lung tissues. Symptoms also seem to resolve more quickly than for previous strains. And I want to point out again that mild does not necessarily mean that milder than previous strains does not mean that it is necessarily a mild infection for people that have it. We also know that vaccines, some monoclonal antibodies, and previous infections with COVID-19 do give reduced protection from infection. We also know, again, for fans of natural immunity, that previous infection with alpha, beta, and delta strains, at least in the US and Europe, have provided very little protection from Omicron and very little reduction in hospitalizations. However, we do know that laboratory studies suggest Omicron could provide substantial protection from previously circulating strains, although this does need to be confirmed in patients and populations. And what that means is if there's a reemergence of Delta and you have been infected with Omicron, you're likely to have some natural immunity or protection from the reemergence of those strains. Next slide, please. And we'll turn it over to Ben.
All right, thank you, Dr. Raymond. Good morning. So I'm going to start off, if we can jump to the next slide, talking a little bit specifically about Milwaukee County and some of the trends that we've seen. So there's a lot of data on one slide, but really we're looking at the general trends that we're seeing. So whether it's cases in the upper left, whether it's percent positivity or tests, we're seeing just really unprecedented numbers. You can see those spikes at the end of the curve. This is the entire length of the pandemic, and you can see those spikes at the end. And especially when we see that spike in positivity, in addition to that spike in testing, we know we have a high disease burden. This isn't just, people who are sick going out and getting tested. This is a lot of people going out and getting tests. And of those folks, a lot of them turning out positive. And of course, unfortunately, that's translating to record hospitalizations. You can see in the upper right there. Our hospitalizations just continue to increase each time we get the data twice a week there. And then just over the last few days, we're starting to see in the lower right a little bit of an uptick in deaths as well. And I think this goes back to some of Dr. Raymond's points that though this is milder, it appears milder than previous variants. When you have this many people that are getting sick, the impact overall is certainly not milder. And we're seeing that in our hospitalizations, and we're just starting to see that in our deaths. I think one of the questions that comes up a lot is when will this end? When will Omicron specifically end? The only country right now that has good data that shows an Omicron peak and then what is a clear decline is South Africa. And when we look at South Africa, when we look at when Omicron first emerged, when it became dominant, to when that peak started going down, and we translate that to the United States, it looks like probably toward the end of the month, toward the end of January, we should start to see a decline in Omicron cases nationally. Now, there's also some suggestion of a decline in the UK, as well as Denmark. It's not nearly as clear as South Africa, but there seems to be a leveling of cases there. So that would imply a little bit of a shorter time to the decline. I think what's important to keep in mind, though, is the United States is big, and we're not being hit evenly. When you look at DC and New Jersey and New York, the cases there started much earlier than the cases in Wisconsin, and out west, we're just starting to see those cases really rising. So we're not seeing this even split across the United States. So I think we'll also see staggered periods of the spike and the decline. So where does that leave Wisconsin? I think best estimates would be that we're at another probably 1 to 2, maybe 3, but I think more likely 1 to 2 weeks until we start seeing a sustained decline in cases. But the other thing to keep in mind is what that decline looks like is also unclear. Whether it's a straight decline right down versus one like we saw with Delta, where it comes maybe halfway down and then it's just staggered. We see ups and downs over months on end. But it's important to remember that even with that decline in cases that may come in the coming weeks, it takes quite a while after that, weeks for those hospitalizations to start to decline, and weeks after that for those deaths to start to decline. So even if we start seeing some improvement in the next couple of weeks, it's going to be a while until we really get past this current Omicron surge. So we can transition to the next slide here. And I want to talk briefly about the role that Milwaukee County in particular has played in the pandemic over the last 21 months. So the UEOC, this is the Milwaukee County City Municipality Unified Emergency Operations Center. This was really key to early planning and coordination for the pandemic. And this was all about cross-sector coordination. The UEOC included government and healthcare, public health, EMS, law enforcement, business, education, all different sectors working together to try to find the best way forward with the pandemic, with an ever-changing pandemic. And of course, based on this being a public health emergency, that coordination started with public health. Now, Milwaukee County is unique. We have 11 different health departments. We don't have a single Milwaukee County health department like every other county in the state does. And so each of our 11 health departments is in a different community. And that community has its own views, its own opinions, its own politics. So you can imagine getting all those communities together to make decisions can be challenging. But they have, and they continue to work together. There's weekly meetings still of all the public health officers talking about strategy, talking about how best to respond and plan for now and the future of the pandemic. EMS and health system engagement has, of course, been critical. EMS EMS, our emergency medical services, our ambulances, our paramedics, through contingency planning to ensure reliable care and response so that when you call 911, you have that response that you need and you get the care that you need. And of course, our health system capacity planning. And that continues to this day, from the very first day of the pandemic back in March, when it hit Wisconsin and hit Milwaukee County, to today. There are still, we still have every other week and now weekly chief medical officer meetings and monthly chief executive officer meetings to talk about what's going on with the pandemic, what is the health system response, and ensure that the health system has the capacity to care for patients in need, whether those are patients with COVID or whether those are patients with heart attacks, with broken legs, with strokes, all the other reasons that people rely on our healthcare systems. The alternate care facility played a key role early on in the pandemic for capacity planning for hospitals. It acted as that overflow for low acuity patients. Next, testing and vaccination aspect. There's no doubt this remains a dynamic process, and testing in particular remains a challenge nationally as well as locally. Messaging, this is a complex virus. Dr. Raymond just talked all about Omicron. Omicron is one variant, and I think in his presentation, he just scratched the surface on the details of Omicron. This virus is changing, it's complex, it's different than what we've seen before, and the science continues to develop, and the politics continue to be overarching. So that messaging has and continues to be challenging. But the county approach has been data informed. We launched the dashboard, our Milwaukee County COVID dashboard early on. One of my earliest memories of the pandemic is we were working on the dashboard, developing what it would look like, and I received a call late at night from our previous county executive, Chris Abley. I hadn't talked to him much at that point early in the pandemic. And he called and he said he's seen the disparities in our community and he wants that on our dashboard. He doesn't want to hide it. He wants it to be front and center on our dashboard. He wants to be transparent so that we can understand it and so that our community can understand it and so that we can improve, so that we can make change and do it in an equitable way. And our current county executive, David Crowley, has really doubled down on that commitment, working to ensure transparency and equity in all of our efforts, whether it's vaccination and testing site placement, or targeting messaging and education, community engagement, and so much more. And also so much more that's in the pipeline and coming in the future. So we can switch to the next slide here. And this is my last slide. I was asked to talk briefly about my own role during the pandemic. So while my home is with the medical college, I've had the opportunity to wear multiple hats with different organizations during the pandemic, including those with Milwaukee County broadly, and then specifically with OEM, the Office of Emergency Management. And you can see some of these roles listed on the right there. So the first is Chief Health Policy Advisor to the County Executive. This has been one of my main roles as I work to advise the strategy of the county on health broadly. Of course, that's been focused mostly on COVID lately. But hand in hand with that position was the medical director for that UEOC, this County, City, Municipality Unified Emergency Operations Center. And that structure was in place for the first 15 months of the pandemic and really guided our regional response early on. Now, before COVID started, my main position with the county that helped to inform these positions was the EMS medical director for the Office of Emergency Management. Now, in that role that I still hold, I'm the medical director for our 14 fire departments in Milwaukee County who provide 911 services. So that's over 1,400 EMTs and paramedics with over 100,000 patient counters per year. The EMS system is interesting. It's truly the front line of healthcare in the community. And it often sees the trends and the warning signs before any other aspect of our health system. Now, in that same vein, our EMS system is also one of the most vulnerable to impacts from COVID. So we've worked hard to develop guidelines and policies and strategies to maintain the integrity of our EMS system to care for every patient who calls 911 in need. And just behind that front line is the emergency department. And I'll say that my time as a physician in our emergency department, I think, has informed my outlook on this pandemic as much as any other role. Those one-on-one conversations at the bedside with the patient, understanding their concerns, their vaccine enthusiasm in one room and hesitation in the next, not to mention the variety of illness presentations that come with COVID and the modifications in treatments that have come over 21 months of different protocols, I think has helped to really keep me grounded in the experience of that individual, while at the same time developing policy for the broader population. And of course, behind all of these experiences is the ability to disseminate the knowledge through my role as an academic physician at the medical college. And that comes through teaching our students, our residents, our fellows, but then also working to publish research on what lessons have been learned, what models have we developed, and what trends have we noted during the pandemic that can inform the response of others. I'd say without a doubt, my favorite part of this job is the variety, being able to bounce between all these different roles in a single day. And each role, without a doubt, improves and informs my ability to perform the other roles. So I'll stop there. Thank you for the time, and I'll hand it to Dr. Cassidy on the next slide.
Thank you, Dr. Weston. Good morning. It's nice to be here again with all of you today. Next slide, please. So back in the beginning of the pandemic, very early on, business leaders started coming to MCW and asking for guidance on how they can navigate safely through this pandemic and how they can create some health and safety protocols. And we recognized right away that this was very overwhelming. It was urgent. There was a lot of information out of there, a lot of information that was constantly changing. So we put together a multidisciplinary team to say, how can we work with different businesses that have very different operations and provide a framework to make it more approachable and more understandable and modifiable? So we came up with this model early on that you've probably all seen, but thinking about how the workforce interacts with customers and the facility. And we realized we have to protect the workforce, the customers, and the facility. And these were all components of protocols to navigate safely. And so we started by creating a checklist of things for people to think about and recognizing that it's different for every situation, but there are common principles. And then you can drill down into any of these. And over time, we learned that masks were highly effective in decreasing transmission. So that became more prominent. And now with vaccinations, that's really the key to navigating safely. Next slide, please. And we all know that there's different risks. And these risks are based on whether you're in an enclosed place, how closely you're interacting with other people, the duration of the interaction, the number of people you're interacting, and whether there's forceful exhalation. All these things increase your risk. So you can see where just different businesses and activities fall into these strata and how difficult it can be and has been to try to figure out how we can move forward with these activities, but do it in the safest way possible and minimize risk. So I've worked with many different individuals and groups across Milwaukee and Wisconsin. And some of the ones I worked most closely with are in that red high risk category. Next slide, please. And so throughout the course of the pandemic, as you know, we've done many webinars, and I've done many with Dr. Raymond, where we have worked with different groups with a variety of different concerns and approaches. And I've done webinars and consultations with school boards, which can be very emotional. Anytime children are involved, it becomes very emotional as we're trying to balance, you know, the child's social, mental, emotional development with protecting them from this very serious disease, and then also protecting the family around them who may have individuals at higher risk. So different families have different risks, so therefore they also have different views on how to handle this, and it becomes very emotionally charged. So we provided webinars where we would tailor it to the different groups, what to think about, without actually giving advice, but, you know, teaching people how to think through these situations and what they need to be aware of and how to balance it. And then for over a year, I participated in weekly meetings with different groups. So Steve Bass, who used to be with the MMAC, organized weekly meetings with restaurant leaders in Milwaukee. And we also had representatives from the health department there and other, you know, Travel Wisconsin and other groups. And so we would meet with the restaurants weekly. And in the beginning, I mean, it was paralyzing, you know, on the restaurant industry. I mean, when you think about the high risk, people engaging, eating, you know, you have to take off your mask, you have to interact. And so it was a really good opportunity to share knowledge, points of view, concerns, frustrations, and try to come up with a unified approach, because a lot of the problem in navigating this pandemic is the inconsistency, when it's inconsistent expectations and information. So for example, when we were talking about, you know, how people really need to wear masks, and there was concern that they would lose business if they required masks, or they would lose employees, how to navigate that. And I know of one restaurant group who actually provided emotional intelligence training to their employees to help them learn how to handle some of these difficult situations and to diffuse them. And then there was reduced restaurant capacity, and some of the smaller businesses just couldn't, it wasn't feasible to remain open during that time. So even throughout this and coming together with unified approaches and consensus, they also managed to influence policy. And one of the big problems, one of the big challenges was if we had stricter guidances and expectations in Milwaukee, then people would start going to other counties that didn't have the same expectations. But on the other hand, there were people who would come to these restaurants because they wanted those safety protocols. And I also started working with United Performing Arts Fund. And so that was really interesting. And so I would meet with them every Friday, and we would discuss their concerns, questions, protocols. I reviewed all their protocols. We discussed them, and they had unique challenges as well, especially if it's a larger site like the Market Center, where they have Broadway shows that are big, that are traveling through and have been passing through other states. And, you know, how do we approach these things? How do we do the protocols? And they did mandate vaccines and for their employees, and they required, many of them also require a vaccine certificate or negative test to attend a show. And we were probably stricter with the protocols in the performing arts than anywhere. But I will say, after all this time, we managed to do it safely. And they managed to move forward and engage and navigate safely. There weren't any major outbreaks, so it does work. And there are ways to do it. It's just a balancing act. And so over the course of this pandemic, I've been really impressed with the people who really stepped up and stepped into a role that they weren't trained to do, that they didn't want, but they did the research, they worked hard. And even if we give advice, they still have to implement the protocols, educate their employees, and monitor it. And that is no small task. So I'm really proud of the work people have done throughout this pandemic. And it's really been an honor to work with the different groups I've worked with. Thank you.
Thank you, Dr. Cassidy, Dr. Weston, and Dr. Raymond. And I'll invite you all to kind of jump back in here and see if we can answer some of the questions. And I know some of them have been answered in the chat. One of the questions is, why not let Omicron run its course? And then we're going to get kind of greater immunity. We're going to get it faster. What are your thoughts on that as a question?
I can start. So I typed an answer to this, but I think it's worth talking through as well, because it's a question a lot of people have. So the question, I think, basically is, why not let it rip? Let everybody get this, whatever natural immunity there is, and maybe bring an end to the pandemic. I think it sounds like a nice idea. Unfortunately, I don't think that's quite how it works out for a number of reasons. So I think there's the individual impacts, and then there's the community impacts. When you think of the individual impacts, one is, and Dr. Raymond outlined this, it's a milder virus on a whole when you look at a community, but it's not necessarily milder on the individual level. I'll tell you, from patient after patient after patient I see in the emergency department, especially for those who are unvaccinated, mild disease, even in those folks, still tends to be sick for days, sick for weeks, laid up in bed, body aches, fevers, chills. This isn't typically just a, stuffy nose and you kind of move on with your day. And even if you have mild short-term effects, you have to think about the long-term effects. And those range from just bothersome to really debilitating for many people. Now, let's just say, fine, you're willing to take those risks on a personal level. And then I think you have to think of the broader community. And so first you have to think of the individuals in the broader community that aren't yet vaccinated. So there's a lot of children that aren't yet vaccinated or aren't eligible to be vaccinated. There's certain people with medical conditions that aren't able to get vaccinated, or the vaccine just isn't as effective because of their immune system. And then those who are at high risk of complications. So whether they're immunocompromised, whether they're elderly, whether they're on certain medications that may make them high risk to get sick, even if they are vaccinated, even if they are boosted, they can still get sick. And so those people you're putting at risk because the virus transmits so readily. And then, of course, you have to think of our health systems. The more people that get sick, a certain percentage of those people, even if it's milder, a certain percentage of those people statistically are going to end up in the hospital. And a certain percentage of those people are going to end up in the ICU, and a certain percentage of them are going to need ventilators. And so the more you let this virus spread, and the faster you let it spread, the more impact it has on the health systems, and the less sustainable it is. And it's important to remember the people who rely on our health systems is everyone on this webinar, everyone who's going to listen to the recording, everyone in our community, at some point or another will rely on our health systems. And it may be because you have a medical condition, or it may be because you walk out to the car and slip on the ice and break your leg, and you rely on the healthcare system. So I think those are a few of the reasons. And then even if you don't care about any of that, there's no guarantee that infection from this virus is going to protect you from future variants. We don't know what variant is around the corner, and it may come from the United States. It may come from South America or Africa or Asia or Europe. We have no idea where it's going to come from and what it's going to be. And so we see that Dr. Raymond talked about, Omicron doesn't really care whether you had Delta or Alpha in the past. And whatever Greek letter comes next may not care at all whether you had Omicron. And so I think there's a number of reasons why we don't want to just kind of let it rip. And those are a few of them.
Yeah. I think I would also like to add that it's actually just much easier to get vaccinated and boosted than it is to get sick and risk getting sick. And there's also many places in the world who don't have equitable access to vaccines. So even if everybody in this country got Omicron, then there's other ones in other countries that'll emerge, and we can't control that through this type of behavior.
So as a related question to that, what happens to previous strains? What happens to Delta? Do they just go away? What happens to those strains?
Maybe I can start, Tim.
Sure.
They don't entirely go away. There may be reservoirs humans or animals, people with immunocompromise, in which these older strains are still harbored and could reemerge. But basically what's happening with Delta is that even though it's trying to be transmitted throughout the community, the susceptible hosts are getting Omicron first. And so there are fewer and fewer opportunities for Delta to spread.
Yeah.
Also point out these previous strains, if they replicate, they can also mutate into something new and different.
Yeah. I know this is a tough question, always forward-looking, Dr. Cassidy. What would you recommend for somebody who's hosting a large group, let's say over 200 people at an event in March? You know, do they plan on meeting in person? Should they switch to online? And I know lots of companies and organizations are trying to think through these forward-looking problems.
Yeah, they're always asking for my crystal ball, but as Weston mentioned, you know, the data suggests that it might start going down, and generally when it spreads quickly, it goes down a little quicker. But I think, you know, what I've been advising people is it's very important to get boosted. It's very important to get vaccinated and boosted, to wear the masks and use the protocols. You know, we've navigated pretty safely with these events throughout the pandemic by just requiring vaccines, negative tests, masks, and you know, all the usual things. So I think that that's really the best approach.
Yeah, Dr. Westman, let me ask you the easy question about mask mandates. You know, the county, as you said, is made up of 14 different health departments. The city is now in the process, it looks like, of working through the Common Council and implementing a mandate. And I'm not picking on them, it's just the nature of government. They debate an issue, they put in a mandate. By the time the mandate gets in, its use may have passed. So what do you think about the mask mandates, given where we are today and what the future looks like?
That's a good question. I don't know if it's an easy question, but I appreciate the question nonetheless. So here are my thoughts. I think two things. One is I think not nearly enough people are wearing masks, considering where we're at in the community. When I go to, I went to the grocery store yesterday and I saw maybe 70% of people wearing masks. Now, if I had gone to the grocery store a month ago, it was probably closer to 30% of people wearing masks. So we're making good improvement. But with the way that this virus is spreading in our community, the way that the hospitalizations in particular are trending in our community, I think more people need to be wearing masks. Number two is, I think we need to change a little bit of our thinking about masks. When I went to the grocery store again, about probably 2/3 to half of those people that were wearing masks were wearing cloth masks. Now, when you go back to the original variant and Alpha and maybe even Delta, cloth masks made a difference. And they still make a difference. Compared to no masks, cloth masks are better. But when you step up to disposable masks, these paper, surgical, or procedure masks, as they're called, they're better. And when you take one more step to KN95 or N95 masks, they're much better. And so I'll tell you, when I go out, I don't really wear cloth masks anymore. And not too often that I wear a paper disposable mask anymore. I throw on a KN95 and I reuse it's sitting somewhere here. I reuse it for a couple of weeks when I'm just going out and about. And it's just as comfortable as the other masks, but it gives me much better protection. And it gives all the people around me much better protection. Because of course, one of the things with COVID is sometimes we have it and we don't know it and we can spread it. So wherever the mask mandates end up, I hope that more people end up wearing masks. And I hope that for their sake, as well as everyone around them, if they can upgrade their masks. And an easy way to do that is the Milwaukee Health Department right now is handing out KN95s at their testing sites. And so that's one way to do it. You'll see more of that coming in the future as well.
Yeah, a little more detailed question here from the Wall Street Journal yesterday. The 2008 Nobel Prize medicine winner for discovering HIV stated a preprint study and recent studies from Denmark and Ontario that demonstrate vaccinated people were more susceptible to Omicron infection. Can you respond to that, Dr. Raymond?
Yes, I think, first of all, these are preprint studies, and I think they were grossly misinterpreted with all due respect to a previous Nobel Prize winner. What I would recommend people do is think about what matters most. Who is being hospitalized? It is the unvaccinated. Who is dying? It is the unvaccinated. These are data that are available from most communities. And I would highlight an article in this morning's New York Times from David Leonhardt, Leonhardt, that shows a growing gap in outcomes between vaccinated and unvaccinated people because of Omicron. So the likelihood that you're going to be hospitalized or to die from COVID-19 is much higher if you're not vaccinated. That's what matters. Please don't rely on somebody's comments about an extrapolation from a single study that's in preprint form. Look at the data that are in your community.
Dr. Cassidy, on your list that you put out ranking, which I thought was very interesting, from low, medium to high, kind of the risks of different engagements, any tips for folks traveling on airplanes?
Yeah, so, well, right now, the rate is so high everywhere. And so that makes it a more high risk activity. The nice thing is that masks are required in airports and they're required on airplanes. But as Dr. Weston mentioned, cloth masks and disposable masks are not as effective as preventing the spread from Omicron. So that's something to consider. We always say consider the rate where you are and where you're going, but right now it seems to be high everywhere. So I think you need to balance the need for that travel with the risk. And, if you absolutely must travel, again, get yourself a KN95 or an N95 mask, board the plane last, try to sit up front where you can get off first, try to stay places where you're not near people, but, and again, make sure you're vaccinated and boosted, but just, you have to weigh the reason for needing to travel with the risk involved in traveling.
Dr. Weston, I think kind of back to you, the question on masks, again, just this is anecdotal, my observations, but, grocery stores, department stores, any place that you go, the vast majority of people are wearing the cloth mask, which I get is better than nothing, but that seems to have a low protection against Omicron. And so it's got to be hard for employers to get this to their frontline employees. And that's part of the big challenge is, people working without what you would say is adequate protection.
I would agree. I mean, I think that if you are a frontline employee, if you're interacting with people in an indoor environment in a close way frequently, I think looking to upgrade your mask is going to be important. Now, KN95s and N95s, you go, 21 months ago in the beginning of the pandemic, they were hard to come by. They were hard to come by for healthcare facilities, let alone for the public. But that's not the case anymore. KN95s you can find online. You order them in relative bulk and they're 50 cents each. These are relatively low prices to pay, I think, to protect people who are on the front lines, whatever those front lines are, whether it's the grocery store, whether it's a factory line, whether it's an emergency department. And we're not talking about masks that have to be one use for every encounter and then you throw it in the garbage. These are masks that easily last a week of use. A lot of organizations I've heard of are giving 2 masks to employees each week. And you kind of, work through those masks. That way, if a strap breaks or if something spills on it or whatever, you have a second mask. But typically that's a reasonable supply to give to keep people with a higher level of protection.
Dr. Raymond, I know this question keeps surfacing, so I'll ask again, why the continued emphasis on vaccine mandates when it's now well accepted that vaccinations do not prevent the transmission of COVID-19?
Okay, thank you, and I appreciate the question, but the way that it was phrased is incorrect and not fact-based. It's certainly a prevalent rumor that we can't extinguish. It's a pernicious meme, whatever you want to call it. The fact of the matter is, if you are vaccinated, you are less likely to get COVID or to transmit it to someone else. It's not an impenetrable barrier, though. And that's why people need to distinguish between the risk of getting or spreading COVID is not completely eliminated by getting vaccinated, but it is remarkably and significantly and consistently reduced. So there is a good reason to get vaccinated. in terms of protecting other people, preventing your own infection, and preventing the serious disease that you may get that could result in hospitalization or death. Clear evidence from every community, every study, very consistent. And that's why it is very frustrating to have to keep answering this question that is really based on a false narrative.
So here's a question for all three of you. And again, I know you touched on this a little bit, but there are a couple questions in here that really go to the point of, are we moving from a pandemic to an epidemic? And is it likely that this is going to continue to mutate for years? And so is it practical every 4 to 6 months to get vaccinated, to get boosters? So what are we looking for what are we looking at as we move forward, I guess is the question.
Well, I can address the first part of pandemic versus epidemic versus endemic. And, we're such a transient society now. We travel across the globe in a day. So even if we have high vaccination rates in this country, we're going back and forth to all these other countries that have low vaccination rates. So until we get those vaccination rates up as well, it will continue to mutate, it will continue to spread. So it may be that it's more of an epidemic in other countries, but it will evolve. And so the more we go, and interact with different cultures and different herds, the more it can still continue to be a problem. I think maybe Dr. Weston or Dr. Raymond can answer about boosting and frequency and add more to that.
Well, maybe I can just start by saying, when people are talking about moving from pandemic to endemic state, that's not going to happen by flipping a switch. It's something that will evolve over time. And what it will mean is that we reach a steady state with the virus where we're not having these huge surges, where we don't have continuing evolution of new, more threatening or more contagious strains, that we have low levels of community transmission, and that we may need minor mitigation measures for the most part, but we will resume a lifestyle that looked very much like what we had before beginning of 2020. We may need to wear masks in winter. This is likely to become a seasonal illness that is prevalent during the winter. But the caveat there is that we have no new drastic changes or emergence of variants like we just had with Omicron and previously with Delta. And in order for that to happen, we need a lower case burden throughout the entire planet because we are a connected society. And if there are low vaccination rates and high infection rates, say in Africa, those will eventually boomerang back to the more developed countries. So we may think that we're in an endemic, but we could be challenged with the emergence of a new variant.
I might just
go ahead, Dr. Weston.
Sorry, I might just add real quick, Tim, that I think there's also the misconception of transmission is a big one. I think another misconception that comes is the idea that since we got a booster at now 5 months, that's going to be an every 5 months sort of thing, another booster. The way vaccines work is often not quite like that. So we did initially a vaccine that was 3 or 4 weeks apart, and that's probably too closely spaced in the long run. Now, there was a reason we did it 3 or 4 weeks apart, and that's because we were in the middle of a crisis. If we all think back to, pretty much a year ago, nationally, cases were on a steep rise and hospitalizations were on a steep rise, and it was becoming unsustainable for health systems. So at that point, giving that 3 to 4 week apart vaccine made a lot of sense. But in the long run, vaccines are typically not 3 to 4 weeks apart. You think of hepatitis vaccines, you think of other vaccine series that many, probably just about all of us got when we were kids. They are staggered. They are a little further apart. And that's to give your body the understanding of that immune response and then reminded of it quite a while later. And so that booster shot is that reminder quite a while later to give that boost to your immune system. That doesn't mean that every 5 months forever, we're going to need vaccines. It also probably doesn't mean that booster is good for the rest of your life. We get tetanus every 5 years or 10 years. We get, a influenza shot every year. We get pneumococcal shots as you get older. There's all sorts of shots that you need on occasion, but I don't think we're entering a state where every 5 months for the rest of your life, we're going to do a COVID booster. I think we're just beginning to see what that time period is, whether it's going to be annual, every 2 years, longer than that, remains unclear.
So the odds are pretty high there's a fourth shot coming at some point.
I think probably at some point there's a fourth shot coming. Yeah, I think that's fair to say.
Okay. Other questions here about, the differences between I don't even know what a KF94 mask is versus a KN95.
Yeah, I can take that briefly. So N95, KN95, KF94, you can think of them all as very similar masks. It's whether it's a mask that's a US accrediting body, N95, Chinese accrediting body, KN95, a Korean accrediting body, KF94. But as long as they're legitimate masks, any one of them is a very reasonable mask to use when you're going around. And as far as finding legitimate masks, you can go to projectn95.org. They outline all these types of masks and which ones are legitimate, where you can buy them from to make sure you're not buying a counterfeit mask, which unfortunately is out there.
Any suggestions on, are there home remedies that will help people recover faster?
Well, let me answer that, Tim, since it's a politically charged question potentially. Let's just say anything that people can do to improve their overall health is useful. So we'll start there. And I don't think that we say that enough. And anything that you can do to treat the symptoms and make yourself feel better and more functional is positive. But in terms of home remedies that are going to accelerate your recuperation from COVID-19, there's no good evidence to suggest that anything in particular works. Again, common sense would tell you, though, if you take good care of yourself and do the things that we all know are good for our health and well-being, that should help you.
Yeah. Dr. Cassidy, what are you hearing from employers? I mean, we're typical of a small employer. We've got about 50 employees, and I would say that we have right now 20 to 25% of our employees are out with COVID. I mean, it's a big issue, not just for the individuals, which is most important, but just for the functioning of an organization when you have that number of people out of work.
Yeah, and this is a really big concern, another balancing act. And I've gotten a lot of questions over the last month or so, or 2 months, about what to do when their children come home positive, especially before they were, vaccinated. Their children were getting sick or they were getting exposed, and then especially if it's something like the symphony and they play a wind instrument, should that person who's exposed come in and play? So this is a difficult dilemma right now with the positivity rate so high. And then there's mixed vaccination status in families because some have younger kids who can't be vaccinated and they're getting sick, and then the parents are getting sick. So I've addressed a lot of questions on quarantine and versus isolation and what the rules are with that. And, if somebody does test positive for COVID, the right thing to do is to stay home, isolate, and until your symptoms improve and you're fever free. And depending on the type of work you do, with some of the performing arts, we're even a little more conservative, and they'll do a rapid test before coming back to work. But I guess to be a little more optimistic, I think that we will be getting through this wave soon, and so it's not forever. This wave is temporary, and so hopefully within a few weeks that will improve.
Yeah, thank you. I know when my kids were younger, Dr. Cassidy, if they weren't playing a wind instrument, the world would have been a better place. So that might have been the upside. But I want to thank you, Dr. Cassidy, Dr. Weston, and Dr. Raymond. Appreciate the responses and also the responses online to the questions. I think this is extremely helpful. Probably won't be the last time we discuss this, but again, grateful for your time and the information. So have a good rest of your day. Thank you all.
Thanks, Tim.